Hello, my name is Man Nguyen and I will be presenting the second subnote for group number 6 today. Our patient DJ, 64 years old, present to the pharmacy with the chief complaining of blood pressure is much higher than normal, even though he is taking medication to have to lower it. Plus, the patient also mentioned that he has a headache, jitteriness, loss of bladder control, and an increased urge to urinate. He also stated that he has been experiencing pain rate 3/10 on a point scale in his joint lately, and he wondered if the elevated blood pressure is due to the pain that he has been having lately in his joint. The patient is oriented to the person, place, and time. The subjective medication history reported by the patient is hypertension and motor vehicle accident with fracture in his scapula and metacarpal 2 years ago. The patient has been using amlodipine 5 mg, ibuprofen 400 mg, and med multivitamin. The report of social history included drinking 4 beers on Wednesday, and the patient report not smoking. For the patient's subjective family history, patient mother died from heart failure at 81 years old. Patient father died from colon cancer at 72 years old. The patient's subjective medical list include amlodipine 5 mg, 1 tablet by mouth once daily. This is well-established therapy for treating his hypertension. The patient also takes ibuprofen 400 mg, 1 tablet by mouth every 8 hours as needed. This is an established acute therapy for his joint pain. Med multivitamin 1 tablet by mouth once daily as a supplement for his health. For objective information of this patient, the patient blood pressure was found to be 167/105 mm of mercury. The respiratory rate was found to be 20 seconds per respiration per minute. The heart rate was found to be 84 beats per minute, and he has temperature of 98.8 degrees Fahrenheit. The patient is African American male, and the date of birth, weight, and height was not identified. For the lab tests were conducted, prostate-specific antigen were 6.2 nanogram per ml. Blood urea nitrogen were 1.7 milligram per dl. His extremities tests were concluded that there is mild inflammation on both hands, visible joint degeneration, urinalysis test results that include leukocytes, ketone, blood are negative. Serum rheumatoid factor were also negative. Our objective finding for this patient include older-looking man who obviously has degeneration of the joint in both of his hands, and a very rigid and crooked. For assessment of this patient, we determine based on the subjective and objective data that the patient is likely have these problems. The most important assessment we make is uncontrolled hypertension, because amlodipine is not controlling blood pressure effectively, and patient kidney function is declining. Thus, addition of ACE inhibition would have controlled patient hypertension and have protect the kidney. We also recommend increased amlodipine dose, which will have controlled patient hypertension. On top of that, patient elevated blood pressure can cause by drug-drug interaction between amlodipine and NSAID, ibuprofen, which reduce the effectiveness of calcium channel blocker. And last but not least, the high blood pressure can cause by lacking of patient compliance. The direct consequences of uncontrolled hypertension and NSAID using a reduced kidney function in patient, indicated by elevating in these lab test values such as blood urea nitrogen, serum creatinine. We also calculate the glomerular filtration rate and to evaluate renal function, and the reason is likely due to hypertension, BPH, chronic NSAID use, and maybe due to possible overconsuming of alcohol. The second assessment about this patient is loss of bladder control, increased urge to urinate. The patient is most likely suffering from BPH indicated by elevated PSA level. Indeed, our patient is 64 years old, African American, and that characteristic are risk factor for BPH. On the other hand, with pertinent negative for leukocyte, ketone, and blood indicated no UTI present and also indicate that type 2 diabetes mellitus is not the cause. The third assessment that we make is joint degeneration, pain of hands, possibly caused by osteoarthritis because of visual deformities and pain, plus patient history of previous trauma to hand from MVA. Patient age of more than 50. On top of that, we can exclude RA due to serum rheumatoid factor negative. The fourth assessment about this patient is headed, potentially caused by high blood pressure, and is also an adverse drug reaction of amlodipine. The last assessment about this patient is gastrinus, possibly caused by being in a high stress situation, emergency room, and increased respiration rate. For the plan for the patient, we conclude with 5 plans needed to be done now. The very first plan aims to cure patient uncontrolled hypertension, which suggests change in amlodipine dose is needed, namely increase dose of amlodipine to 10 mg once daily. To improve patient kidney function, we also suggest additional ramipril 2.5 mg once daily to protect the kidney function and treat hypertension. On top of that, we also counsel patients to continue monitoring blood pressure to make sure he is responding to medication change. On the other hand, we suggest patients should stop using NSAID due to water retention and worsened hypertension and kidney function side effects. However, if patients have to use NSAID to cure pain, we recommend patients to use acetaminophen 325 mg to tablet by mouth every 4 to 6 hours as needed or glucosamine sulfate 1000 mg once daily instead of ibuprofen. We also counsel patients to avoid alcoholic drink and using other drugs, included acetaminophen when taking acetaminophen. We also mentioned about patients can also take acetaminophen acutely along with glucosamine sulfate until he sees full therapeutic benefits from glucosamine sulfate, which is up to 1 month. The second plan is aimed to cure patient loss of bladder control, increase urge to urinate. First of all, we recommend patients to seek medical attention to evaluate elevated PSA, such as digital rectal exam, in order to determine cause, which is caused by BPH or not. If patient is diagnosed with BPH, we recommend an additional drug should be used, and it is tamsulosin 0.4 mg once daily. It should be taken 30 minutes following the same meal each day. Patient may increase up to 2 capsules, 0.8 mg once daily after 2 to 4 weeks if patient doesn't respond to 1 capsule. We also encourage patients to monitoring blood pressure to make sure it stays within normal range, as the drug may cause a drop in blood pressure. The third plan is aimed to cure patient joint degeneration or pain in his hand. We suggest patients seek medical attention for a diagnosis. Namely, we recommend DEXA scan to diagnose the osteoarthritis by evaluating the patient T-score. Evaluate T-score since our patient is a male over age of 50 years old. If patient is diagnosed with osteoarthritis, we would recommend continuing with either acetaminophen 321 mg every 4 to 6 hours at needed for pain, or glucosamine sulfate 1000 mg once daily. The fourth plan is aimed to cure patient headache. We will make sure patient is well informed about acetaminophen 325 mg he is taking for his joint pain can help him with his headache. Also warning the patient about the side effect of tamsulosin 0.4 mg, which can be headache. On top of that, we recommend patient take note of his headache to see whether it is improved or not. If it gets worse, he should seek medical treatment for further testing. The last plan is to cure patient chystitis. We suggest reassessing this symptom once the hypertension, bladder issues, and hand pain is under control. This may be a secondary symptom from the patient or the medical condition and may resolve itself once they are under control. Thanks for listening.